Okay, Assalamualaikum and good morning. My name is Dr. Shazia Maqsood. I am consultant obstetrician and gynecologist at Dr. Suleiman Al Habib Hospital in Riyadh. And I'm also a teaching professor for the training program in OB-GYN here. So a very warm welcome to all of you. Today's topic that we are going to discuss is major obstetric hemorrhage, and we are going to talk about the causes and the management. In the OB-GYN, this is the most important topic as far as your exams are concerned, as far as your preparation are concerned, and also if any one of you wants to have a career in OB-GYN, this is the part and parcel. The obstetric hemorrhage treatment and management is the part and parcel of your reading curriculum as well as your day-to-day practice. So basically today the learning points, the key learning points would be that we will talk about antepartum hemorrhage or hemorrhage that occurs during pregnancy. And we will also talk about postpartum hemorrhage, hemorrhage that occurs immediately after delivery or a bit later. And we'll talk about how to make an efficient team to be able to practice how to prevent this, and if it happens, how to effectively treat it. So without much further ado, let's go into a bit of background of obstetric hemorrhage. It is a leading cause of direct maternal death all over the world, be it the developing world, be it the developed world, be it the underdeveloped world. It's the leading cause of maternal death, direct maternal death. So almost about 27.1% of maternal deaths are attributable to obstetric hemorrhage. No matter how good a maternity unit is, no matter how well trained the staff is, or no matter how poorly trained or poorly arranged the labor room is, the maternal death is imminent if it is a bad and a major obstetric hemorrhage. So more than 2/3 of reported deaths all over the world, maternal deaths all over the world, according to the WHO, are because of obstetric hemorrhage. So you can see how important it is to understand the salient features which would go into treatment of that. Now, we differentiate the maternal obstetric hemorrhage into antepartum hemorrhage, which is bleeding from the 24th week of gestation until prior to birth. And we also differentiate it into postpartum hemorrhage, which is about 500 mils of blood loss after normal delivery and 1,000 mils of blood loss with a cesarean delivery. And postpartum hemorrhage can be a primary postpartum hemorrhage, which is within the 24 hours, first 24 hours of birth, or it could be secondary, that the woman has gone home and then a bleeding happened, and this can happen within up to 12 weeks of birth. So that is more spurious, that is more ominous, because she's at home and she is away from medical help. So let's talk about causes of antepartum hemorrhage. The causes of antepartum hemorrhage are placenta previa, where the placenta is low-lying. Instead of on the upper edge of the womb, the placenta goes at the lower end and it is attached over there, and hence it causes bleeding. This is imminent in 31% of cases of all antepartum hemorrhage. The other causes of antepartum hemorrhage are placental abruption, 22%, or even a marginal placenta, which is most common, which is 60% of the placenta is low, not high, and it still causes bleeding. Other causes of antepartum hemorrhage could be vasa previa, or a slightly heavier show, or trauma to the genital tract, or infection to the genital tract, or tumors. Now, when we talk about causes of postpartum hemorrhage, we need to remember that once the lady is delivered, once the mother is delivered, we need to remember 4 T's. The first T is the tone, the uterine atony. The uterine atony, or the laxed uterus or the relaxed uterus which fails to contract, is attributable to postpartum hemorrhage in about 75 to 90% of cases. There are other reasons like trauma to the vaginal tract, trauma to the cervix, especially if you have done an assisted vaginal delivery with the Kiwi-1 tubes or with a forceps, so that can also cause postpartum hemorrhage. Or retention of tissue, or the placental pieces retain inside, and that is causing bleeding. Or thrombosis, which is any bleeding disorder, any clotting coagulopathy, congenital or acquired. So these are the 4 T's that we need to remember: the tone, the trauma, the tissue, and the thrombosis. So we will be talking about the 4Ts a lot in the next few slides, so pay attention to that. So what happens when an antepartum hemorrhage happens? So somebody would come to the ER or come to the A&E with a vaginal bleeding, and this is common in 80% of cases. And there could be abdominal pain, and there could be uterine contractions because she's pregnant, and the lady could be in a hypovolemic shock. So basically what we are trying to do is trying to assess, do the ABCs and calling for help. So on palpation, there could be two types of problems. One is a concealed type of hemorrhage that you might feel that the tummy is very hard as a stone, or there could be no pain at all. It is called partial type of abruption or partial type of bleeding. So our main cause of concern when an antepartum hemorrhage is happening is twofold. One is maternal well-being and one is the fetal well-being. So the whole team involved need to make sure that the mother is stabilized and we are able to save the baby as well. So you cannot do the job alone. You have to call for help. You have to call for a senior obstetrician. You have to call for a senior midwife. You have to call for the baby doctor, the nursery doctor, pediatrician. You also have to call for the anesthetist because you may need to deliver with a cesarean delivery. You also have to involve the hematologist because you will need a lot of blood for this lady, and so on and so forth. So the next few slides will be about how to manage these things. So if a lady is less than 34 weeks pregnant, she will need an admission. She will need bed rest. We give steroids to boost up the baby's lungs. We send bloods for a full blood count, a hematocrit, blood group and save. And do not discharge such ladies who come with antepartum hemorrhage unless they live very close to the hospital, like 5-10 minutes, and they can easily come back. Aim to deliver such ladies around 37 weeks. And if she's severely bleeding, obviously you will need to have an emergency cesarean section for her. Now, if the gestation of pregnancy is 34 to 38 weeks, then again, apart from all the rest of the things, you may need to deliver her. If she has a low-lying placenta, examine her and see if you can feel the placenta, then you need to deliver her with a cesarean section. But if you do not feel the placenta, then she can have a trial for normal delivery. And every good labor room is always prepared for major obstetric hemorrhage, hemorrhage due to placenta previa, hemorrhage due to marginal placenta. So as I said before, there has to be an interprofessional multidisciplinary teamwork for this kind of a case, where you have the obstetrician, the midwife, the anesthetist, and the neonatologist on board for such kind of case. So basically, you will call for help. You will do the ABC resuscitation, airway, breathing, and circulation. You need to have 2 large bore IV access, 2 cannulas. You need to send the bloods, full blood count, urea and electrolytes, coagulation profile, and a group and save and cross match. So in such cases of blood loss, vaginal loss, always remember to send ample amount of cross match. I would recommend 4 units of cross match. That is a standard all over the world by the Royal College of Obstetrician and Gynecologists UK and by the American College of Gynecologists. So fluid replacement. So while the blood is being arranged, you make sure that when you have put in the 2 IV cannula access, give some Volumen, give some plasma expanders while you're waiting for the blood. Sometimes getting the blood on board can take as long as 20 to 30 minutes because that's how long a cross match can take minimum. So you can have somebody run down to the lab and get you uncross matched O negative blood before anything else. So that is a major lifesaver, and that is what bleeding protocols in the labor room state, that do not wait for the cross-matched blood. If you feel that the bleeding is too much, then access uncross-matched O negative blood, as well as start plasma expanders early. So if it is a placenta previa causing the antepartum hemorrhage, typically it's a painless bleeding. Patient will not suffer from any bleeding, so you have to assess the amount of bleeding and then act accordingly. And this could be very sudden. I remember last week we had somebody coming to our ER, and the husband was carrying the wife on his hands, and she was bleeding. And he was wearing white clothes and it was all red. So it can be very dramatic and it can be catastrophic as well. Luckily, we were able to save the mother and the baby both, but not always the outcome is so good. In cases of placental abruption, there is a premature separation of placenta due to bleeding, and blood can be concealed within the uterus. So the patient can present with hardening of the belly, pain, and you can assess that when she could be having placental abruption, and then again you need to rush for delivery. And there are other causes like vasa previa, or the vessels of the placenta being on the corner of the placenta that can tear away very easily in utero and cause torrential hemorrhage, which is life-risking for the baby as well as for the mom. And there could be a uterine rupture. There could be, the patient could have had a previous cesarean section and is in labor and can have a uterine rupture. And these things, believe you me, they are very, very common. They occur on a weekly basis in a busy labor room. We had a uterine rupture about 2 weeks ago. The lady was for a vaginal birth after cesarean section. She had a previous cesarean section about 4 years ago for breech presentation. So we approved her for a vaginal birth after cesarean. She was fully dilated within 6 hours. And once she started pushing, we experienced that she was having blood-stained urine. And then we take her for an emergency cesarean section, and we found that she was complete rupture. Luckily, we were able to save the baby and the mother. So it's not something that is very uncommon. Okay, let's talk about the postpartum hemorrhage. Now, this one, out of the two hemorrhages, the antepartum and the postpartum hemorrhage is the one which is more sinister. 14 million mothers develop PPH each year globally. These are the WHO figures, 14 million. So basically what happens is that 99% of the death in the developing countries for the mothers are because of postpartum hemorrhage. And PPH can also lead to hysterectomy and severe anemia. So this is a major cause of concern for the labor rooms all over the world. So again, remembering the 4 T's of postpartum hemorrhage: the tone or the uterine atony, the trauma or the lacerations or rupture, the tissue or the retained products, and the thrombin or coagulopathy. These are the 4 main common causes. The commonest one is tone. So anywhere in the world when we do our obstetric drills for the postpartum hemorrhage, the first thing that we teach the junior doctors is how to check for the uterine tone. So like if you are checking for the uterine tone, the uterus should be well contracted and it should feel like a big globular firm structure. And if you are feeling that it is not globular and it is very boggy, that means that the tone of the uterus is not fine. So you start massaging the uterus from the top and from the bottom, as well as start giving uterotonic medications to curb the atony. And in 90% of the cases, that is the cure of the postpartum hemorrhage, primarily if it is recognized immediately and if a bimanual massage and uterotonic medications are given on time. Okay, so let's talk a little bit more about the tone. It's because of the abnormal uterine contractility. You know that uterus has an endometrium, which is the inner lining of the womb. Uterus has the myometrium, which is the muscle. Sometimes the uterus, which should normally contract on itself after delivery, that does not happen. It can happen in cases of multigravidity, it can happen in cases of twin pregnancy, it can happen in cases of polyhydramnios, it can happen in cases of obesity, it can happen in a lot of other cases as well. So the uterine atony or overdistension causes the muscle fatigue. So also if somebody is infected, inflammation due to infection like chorioamnionitis can cause uterine atony. Let's talk about the second P, the tissue. That could be because of placental complications, placenta accreta, that is the placenta which is encroached upon the myometrium. Normally the placenta is within the endometrium, and after the baby delivers, the endometrium separates the placenta and the placenta comes out. In case of placenta accreta, increta, or percreta, these are the ominous kind of placenta which has abnormal seedling into the muscle of the uterus and they will not come out easily. and they will tear the planes of the muscle and cause torrential hemorrhage. And again, it could also be because of placental retention, that the placenta does not come out completely, or it could be because of placental abruption. So the hemorrhage due to tissue retention is also a very torrential hemorrhage and practically life-threatening. I was talking to one of my colleagues in Gujarat, Pakistan, the other day. She's a professor there in one of the university hospitals. And she was telling me that they have an epidemic of placenta accreta in their area. And every month they are getting at least 4 or 5 placenta accreta. And they are ending up having a hysterectomy. And the maternal morbidity and mortality is being very high because of that. So again, one of the high risk factors for placenta accreta is previous cesarean section. So a lot needs to go into planning for cesarean section and looking into the cause of doing repetitive cesarean section, and perhaps minimizing the amount of children a woman is having after multiple cesarean section to prevent imminent maternal death or maternal morbidity or fetal death or fetal mortality. Okay, let's come to the third T, which is trauma. Trauma means physical injury. So if there's a big baby, or if we have used a kiwi worm tooth, or if we have used a forceps for delivery, it can cause a laceration of cervix, of the vagina, or of the perineum. And that can cause trauma. Also at the cesarean section during an operative delivery, the cut of the cesarean can extend to the angles of the uterus and can cause torrential hemorrhage. If somebody is a grand multipara, if there is a previous vertical uterine incision, that can also cause trauma. Then we come to the fourth T, that is the thrombin. Excuse me for a second. Thrombin, as the name suggests, this is due to the clotting factor. So say, for instance, if somebody has had a bleed of 500 mils, let's say that somebody was pregnant with a hemoglobin of 10. She came for delivery when her hemoglobin was 10. Normal range is 12 and above. So she was anemic when she entered the labor room. Now then after that, she had a bleed, postpartum hemorrhage of about 1000 mil, 1 liter. So basically she drops her hemoglobin and she can easily go into a consumption coagulopathy where she loses her red cells, where she loses her platelets, where she loses important coagulation factors. So basically she can go into disseminated intravascular coagulation and hyperfibrinolysis. And there are medications available for all kinds of hemorrhages, but this kind of hemorrhage in particular needs blood products and blood replacement. So basically, when we talk about treatment for postpartum hemorrhages, the tone, the tissue, the trauma, the thrombin, this one is the most lethal one, which can cause maternal death. Okay, so let's have a small sort of an algorithm, a visual summary, I call it, and this is in accordance with the guidelines of the Royal College of Obstetricians and Gynecologists. This is a suggested approach to management for all the possible causes for a primary postpartum hemorrhage. Primary means within the first 24 hours of delivery. So if there is a poor uterine tone, feel the belly, the uterus feel relaxed and boggy, and the fundus may be felt above the umbilicus. So if the uterine cavity is filled with bloods and blood clots, so send a full blood count, send a coagulation profile, send Usenes, the urea and electrolytes. If the patient is not responsive to fluids and blood replacement, do an abdominal ultrasound to exclude a uterine rupture or an intraperitoneal bleeding. How would you manage such a patient? You will give them oxytocin. These are specific drugs, and we'll talk about it in a later slide. You will give her prostaglandins. You will give her ergot alkaloids. You can also do a uterine balloon tamponade. We'll explain that to you in a bit. And we'll do the hemostasis algorithm, and we will tell you what's this stepwise management for hemostasis. H is for call for help, A is for ABC, and so on. So that's an algorithm for hemorrhage. Then in case of tear or trauma, again, there's bleeding from the area of trauma with the genital tract. You'll be sitting at the perineum and you'll be looking at the trauma. you need to have a good light source at your back. You need to have good assistant who can expose the area to you, and or there is a uterine rupture, so or extension of uterine angular to cesarean section. So extragenital causes such as subcapsular liver rupture or rupture of ovarian and splenic vessels should not be overruled, and that you can diagnose at the time of doing a laparotomy. So again, the investigations are going to be the same, plus an ultrasound. And also you need to do a laparotomy, or if it is at the cesarean section, you need to exteriorize the uterus, bring the uterus out, and then check if it is extended or not. So the management is a repair of identified genital tract trauma, and or pelvic arterial embolization. So sometimes the bleeding is so torrential that you're not able to manage by giving the sutures alone. So you need to take help of interventional radiologists to embolize the pelvic arteries. And we'll talk about it in later slides. Now talk about the third T, the tissue. Again, a retained placenta or membranes, the common sense is take the patient to the theater, give her some anesthesia, and remove the placenta out or scoop the placenta out. It's like called a manual removal of retained placenta, or MRORP. So again, management depends on what is the cause for the retained tissue, and then replace the lost blood. In case of a coagulopathy, there's a continuing bleeding and contracted uterus. It happens a lot of times. We had a BPH recently where I was being called at 3 a.m. by a colleague who was doing an emergency cesarean section in a priming gravida who had an obstructed labor, and she was having too much bleeding. So I was called at 3 a.m. So I took about 20 minutes to reach to the hospital. And then after that, by the time I reached, I noticed that she was having bleeding from the puncture side, from the cannula side. So she was already in DIC. Luckily, our blood bank is very fast and efficacious, and we were able to arrange fast bloods and cryoprecipitates and plasma expanders for her, as well as factor 7, recombinant factor 7. So we were able to save grace and save her life, alhamdulillah. So things happen in labor room when you're least prepared, and for that reason, we have to be always prepared. Okay, so the investigations for coagulopathy, again, a full blood count, a coagulation profile. What is a coagulation profile? Is PTT, PT, INR, urea and electrolytes, and manage it with immediate replacement of blood and coagulation factors and platelets, and surgical only with trauma or atonic hemorrhage, which is unresponsive to medical treatment. And surgical treatment means that you are going to remove the uterus or do an emergency postpartum hysterectomy. So this is sort of a visual summary about postpartum hemorrhage, primary postpartum hemorrhage within the first 24 hours. So again, explore the cause. Is it an atony? Is it a retained placenta? Is the uterus involuted or not? Are the vessels okay? Is she not going into DIC? Are there any cervical lacerations? Are there any vaginal lacerations? Or are there any perineal lacerations? So assessing the patient yourself is very, very important. Now, let's talk about secondary postpartum hemorrhage, which occurs from 24 hours to up to 12 weeks after delivery. The most commonest reason is endometritis or infection. The patient could present with uterine tenderness. She could present with guarding and rebound tenderness. She could come in with fever, foul-smelling vaginal discharge. You need to do an ultrasound to exclude retained products of conception or a pelvic abscess, and you need to do high vaginal swabs and blood cultures. Start oral antibiotics immediately and admit to hospital for IV antibiotics if she is unwell or hemodynamically unstable. You do serum lactate for such patient, and if the lactate levels are 4 or above, this is an immediate admission for high dependency unit. Another cause for secondary postpartum hemorrhage could be pseudoaneurysm of the uterine artery. Again, it's a profuse bleeding. Patient can be shocked more than 24 hours after childbirth. You need to do a Doppler ultrasound, an MRI, a pelvic angiogram for that. And management is surgical, uterine artery embolization, and also medical, give antibiotics if there's coexisting infection. and correct the blood volume. So you have to have a multidiscipline for that. Again, you need to involve the hematologist, you need to involve interventional radiologist, a senior obstetrician, as well as the anesthetist. It could also be because of retained tissue. Again, the patient can be presenting with fever, foul-smelling vaginal discharge, uterine tenderness. Your investigation will include an ultrasound to confirm the RPOCs and to exclude a pelvic abscess. And the management, again, is antibiotics, admit if you think she's unwell, and surgical evacuation of retained product once she's stable, and consider expectant management in mild cases. Mild cases means you did an ultrasound and the uterine thickness, endometrial thickness was about 25 millimeter or 26 millimeter. Don't go in for evacuation. Try to manage her expectantly, unless there are big blood clots or cystic spaces in there which are more than 3 to 4 centimeter or 5 centimeter. Then definitely stabilize her, give her IV antibiotic, and go in for an evacuation. Okay, so this is our hemostasis algorithm for management of postpartum hemorrhage. H is ask for help. A is your ABC, assess and resuscitate. E is to establish etiology. Which of the T's is the tone, the tissue, the trauma, or the thrombin? Massage the uterus without even doing anything else. Start massaging the uterus. So any good obstetric unit, the person who will give the first call for postpartum hemorrhage will be the one who will already be starting massaging the uterus. Oxytocic administration. Oxytocins are the lifesaver drugs in the labor room for prevention of postpartum hemorrhages, and they are available. You have to have a postpartum tray or a postpartum trolley. They are the part and parcel of all emergency maneuvers in a labor room. So you have to have a PPH tray. So oxytocics are the medications which are kept inside the PPH tray. And then S is for shift to OT. T is for tissue and trauma to be excluded and proceed to tamponade. A is to apply the compression sutures. S is for systemic pelvic devascularization. I is for interventional radiology. And S is for, if everything else fails, go for a subtotal or a total hysterectomy. So that's the hemostasis algorithm for dealing with postpartum hemorrhage. Okay, so early resuscitation is the key. Have the OB at the bedside, monitor the vitals and patient status, 2 large bore IV access, cannula and necessary lab work, administer oxygen, administer IV fluid, resuscitate, type and screen, and put 2 units of PAC RBCs on hold. So the 3 key points to know about postpartum hemorrhage is prevention, access for the 4 T's, and early resuscitation. So how would you prevent? Identify early risk factors. I always tell my junior doctors, please treat the anemia before somebody comes into labor. That's the most vital thing. Treat any infections before anybody comes to labor. Identify the risk factor. If she is twin pregnancy, if she's polyhydramnios, if she's multigravida, if she has a previous history of PPH, always make sure that you have an active management of the 3rd stage of labor, which means administering routine oxytocics at the delivery of the shoulder of the baby rather than waiting for a PPH to happen. And when you're removing the umbilical cord, you have to have a controlled umbilical cord traction. Do not pull unnecessarily. Do not tug on the placenta. Let it separate and let it come out easy. And always remember that up above the uterus, there is a bladder, and sometimes the bladder is full, and because of that, it is not allowing the uterus to contract. So whenever you experience atony in the uterus, please empty the bladder. Okay. So let's come to uterine atony, which is 70% of PPH. The treatment is fundal massaging, uterotonic medications like oxytocin, which is 10 international unit IM, and also you can put up to 40 international unit IV in an infusion and run it 125 mils per hour. You can give Cytotec or misoprostol. It comes in a 200 microgram tablet. You can give up to 8 tablets, up to 6 to 8 tablets, and you can give them per rectally, or you can put them directly inside the uterus or in the vagina. You can also use Methergin 0.2 milligram IM. Always remember, if somebody has pre-eclampsia, do not give Methergin, avoid Methergin. Hemabate or Carboprost can also be given 0.25 IM. and always remember to empty the bladder. So uterine atony, we have to use all those medications, and all those medications are should be readily available in any busy obstetric unit in terms of a PPH box. If it is a retained placenta or a tissue problem, inspect the placenta for missing pieces. So the placenta which has already been removed, open that, check, put your hand and see if it is smooth. If it feels that there is a cotyledon missing, go back, do the ultrasound and manually remove the placenta. If it is a laceration or rupture, that's 20% of PPH. It's very, very common actually. Inspect for laceration in good light, good assistance, if there's a hematoma, and then repair any tissue trauma or evacuate any hematomas. If it is a thrombin deficiency or a consumption coagulopathy, that occurs in less than 1% cases of PPH. So obtain all the labs, which is the CBC, PT, PTT, INR, fibrinogen level, and consider giving fresh frozen plasma, factor 7A, platelets, and assess the history of any hemophilia, take a proper history, or von Willebrand disease, or ITP, or TTPs, or other bleeding disorders. One way of asking is, are your periods normally very heavy? Do you pass any clots with your period? Is there anybody in your family, your mom, your aunties, your sisters having heavy periods? So she should be able to, or a relative should be able to volunteer some history for you. Now, tranexamic acid. Tranexamic acid is a very important drug, a very cheap drug to control immediate postpartum hemorrhage. And all over the world, there have been great progress upon studies and research gone into tranexamic acid, which is now saying that tranexamic acid, if given within the first 30 minutes, can prevent postpartum hemorrhage very, very effectively. So what I have started doing for the last 2 or 3 years now is that on my cesarean section, if I'm doing an elective cesarean section, routinely after the delivery of the shoulder of the baby, I ask the anesthetist to give 500 milligram of tranexamic acid IV, and I'm not seeing any PPHs thereafter. So which is great. So you have something rolled up your sleeve, which is perfect. Okay, some gross pictures over here. The one over here is one of my patients who had a PPH due to placenta accreta, and this is the amount of blood on the lap sponges. So you can see she bled quite a bit. So when we come about the estimating of blood loss, if there is a sanitary towel half soiled, it is 30 mils. If a 4x4 swab, a small swab, is completely soaked, it is 60 mil. If it is a saturated sanitary towel, it is 100 mils. If on the Anko sheet or an incontinence pad, there is a stain in the center, it is 250 mil. If there is a floor spill, it's already 500 mil. A full kidney dish is also 500 mil. If there's a blood spilling on the bed, it is already 1 liter or 1000 mil. If there's a blood spilling on the floor, it is 2000 mil. And always remember, this is an estimation of the blood loss. Estimation means that whatever you're estimating, please do it with one of your colleagues, let them reconfirm it for you, and then add about 400 to 500 more to that. So that will be your actual blood loss. So yeah, it can be that gross, it can be that serious, and it needs immediate replacement. So the Advanced Life Support and Obstetric have an excellent algorithm for team management of postpartum hemorrhage. As I said before, we need a lot of people in the room, and the head person, the person at the head end, will check the airway, will check the breathing, will administer oxygen, and will make sure that the patient is lying flat, and will note the time of relevant events. At the arm, the person at one of the sides will check the pulse and blood pressure, will establish 2 large IV bore cannulas, will check the blood count, clotting, cross-matching 4 to 6 unit, will start the fluid resuscitation, and will start with 2 liters of crystalloids. Will also be responsible for administering drugs like oxytocin or syntocinon, ergometrin, prostaglandin, etc. Okay, so the person at the bottom end, this person here, the call for help, because this person is going to examine and then determining whether they are going to stay inside the room or going to take to the theater. Call for help, start massaging to stimulate a contraction, coordinate with the helper 1 at the head, coordinate with helper 2 and at the arm, and if the bladder is full, Please empty with the catheter. If atony persists, apply bimanual compression. We will talk about how bimanual compression is done with one fist inside the vagina and one hand on top of the belly. And review other causes, the 4Ts, the tone, the tissue, the trauma, and the thrombin. And move to surgery fast if the bleeding persists. So like it's your call basically if you're at the bottom end of the patient, that how soon you move to the OR, the better it is for the patient and for the outcome. Okay, now so something about the medical management of postpartum hemorrhage. Talk about uterine atony. That's the bimanual massage. That's how the bimanual massage is done. You put in your hand inside the vagina, make a fist, and try to compress the uterus like this, putting your fist on the anterior part of, above the cervix, and bimanually on the belly, you are compressing the uterus. The idea is to compress the fundus of the uterus between the two hands, and it works excellent because after delivery, the belly is relatively very, very lax, so it is very easy to do that. As gross as it might look, this is actually a lifesaver. And if you can see over here, this is the bladder. So if it is full, then you might have problem in getting a full compression of the uterus, or the uterus might not contract completely. So make sure you empty the bladder first and then do this. Okay, so now I made up this visual slide. So I always like the idea of teaching with visual aids. So these are the medications which are available in the market. These are the medications which we put in a PPH emergency box in our labor room. These are the medications which need to be replaced each time a PPH happens. The first thing, the part and parcel of the PPH box is syntocinon, which is a synthetic oxytocin. It comes in 5 international unit vials. It has 5 ampules in a box, so 5 times 5 is 25. And as I said before, you can give up to 40 units in 500 ml saline, fast drip, 125 ml per hour, after giving a 10 unit bolus IV also. So that's the mainstay of your treatment for postpartum hemorrhage. You also have methogen, which is 0.2 milligram. One box contains 20 ampules, so you can give 1 ml IV, and you can repeat it after 10 to 20 minutes. This is the one which needs to be avoided if there is high blood pressure. Pabal is relatively newer in the market for the last couple of years, and it is the carbetocin. It is fantastic. I am using tranexamic acid as well as Pabal. So my shout out to my anesthetist at the time of cesarean when there is any PPH is, please can I have Pabal and can I have tranexamic acid? So I combine these two for my PPH prevention. So which is fantastic. Prevention, I'm saying, not when the PPH is happening. I'm using these two routinely for prevention of PPH. So on the delivery of the shoulder of the baby, I would ask for a tranexamic acid and a Pabal combination, and voila, there is no PPH. If the patient is having a vaginal delivery, if I'm doing instrumental delivery like a kivi or a forceps, I prefer giving Pabal. Again, because it is available in my labor room. If there's not, then tranexamic acid is a cheaper and a much more readily available option as well. So you can ask the nurse to give a tranexamic acid. So that's again is a prevention of PPH, not waiting till it happens. Okay. The cheapest option for treatment for PPH is the misoprostol tablets. These are called Cytotec. They come in 0.2 milligram or 200 microgram. They are diamond-shaped tablets, and they can be used. They can be given about up to 8 tablets. They can be inserted PR. When you are inserting them PR or PV or intrauterine, make sure that you wet the tablets a little bit with sterile water. So let them crumble a little bit in your hands, and that activates the active ingredient misoprostol within the tablets. And then you insert it. It will work like that within 5 to 15 minutes. Okay, and then we have the Hemabate, which is 250 microgram. It is slightly more expensive than Pabal, but it is also, if it is available, it's fantastic. It can be given like a jab within the uterus, within the fundus of the uterus, and work fantastic if you're having a PPH at the time of cesarean, or if you have the uterus open. It can be given within the myometrium, endometrium as well. Okay, and then we have the recombinant factors, activated factor 7A. Again, has to be given IV, has to be given in the setting of where you have involved the hematologist, you have involved the high dependency unit internist, and they will be the ones monitoring the giving of recombinant factor 7A. So these are the medications we will revise again: syntocinon, metrogyne, Fabal, misoprostol, tranexamic acid, recombinant 7A, and hemabate. We were talking about the tranexamic acid. Again, with immediate treatment, there is 70% improvement in atony, as well as tissue trauma. Also for tissue trauma, tranexamic acid is very, very good. It comes by the name of cyclocapron, and if somebody is bleeding excessively from an episiotomy site or an extended episiotomy causing bleeding, you can also ask for this. Every 15-minute delay, there's a 10% decrease, and then after 3 hours, there's no benefit. So give it immediately. It works perfect. So tranexamic acid or cyclocapron injection is a drug that stops bleeding. And there was a large woman trial. 20,000 women in 21 countries in 193 hospitals were examined, and 1 out of 3, the drug can save 1 out of 3 women who would otherwise bleed to death after childbirth. So an estimated 100,000 women die from severe bleeding after giving birth every year. The drug reduced the number of women bleeding from death after childbirth by more than 30%, and it reduced the need for urgent surgery to control bleeding by more than 35%. And it's very cheap. So no harm in informing your labor room staff about tranexamic acid. It's called cyclocapron. It comes in injections. It comes in pill form. So keep that as a lifesaver in your labor room PPH box. Let's talk about blood and blood products. We have got red cell concentrate, we have got fresh frozen plasma, we have got platelet pools, we have got cryoprecipitates. So all of them are very, very important. And when you are activating a major obstetric hemorrhage protocol, like if somebody has bled more than 2 liters, please activate major obstetric hemorrhage protocol. So all good hospitals, all good labor rooms have a major obstetric hemorrhage protocol for the sake of risk management. And the risk management team involves the hematologist and involves the blood bank, and you immediately order for 4 units packed cell RBC, 4 to 6 units of fresh frozen plasma, and cryoprecipitate and platelet pools if and as when necessary, after checking the fibrinogen levels, after checking the PTT, PT, and INR levels. Okay, so this is how you, if we talk about the tissue or retained placenta, this is how you manually remove the retained placenta. So obviously, as you can see, that whole of your hand will be going in. So your own safety is that you wear large gauntlet gloves which cover up to the elbow. And also the patient needs anesthesia. So if she is not under an epidural, this has to be done inside an operating room where there is facility available for immediate general anesthesia or an immediate spinal anesthesia. And then you put your hand inside and you scoop the placenta out. So the tip of your fingers are actually your eyes, and you're feeling and you're scooping it out. And then after that is done, do an ultrasound and to check that the uterus is now completely empty. And you replace any blood loss, and you make sure that you give antibiotics, because this is an invasive procedure. Your hand is going through the vagina, so there is a risk of infection. So IV antibiotics would be the call of the day for such tissue retention. It's common, it's not uncommon at all. It happens, and it's easily sorted out in expert hands. Now let's talk about the balloon tamponade. So all good labor rooms also have a gadget, a gizmo called a balloon. It is called a uterine balloon. There are several companies which make uterine balloon. One is the Cook's catheter, one is the Bakri balloon. So, and whichever way it is, this is how it is inserted through the vagina, through the cervix, and then it is inflated under ultrasound guidance, so that you know that it is occupying the major length and width of the uterine cavity. You leave it like that for 24 to 48 hours till the PPH stops, and then you deflate it, and then you take it out. So it is effective mainly in the uterine atony. You need to continue to monitor the vitals and blood works closely, and replace any bloods or any consumption coagulopathy. And if the tamponade fails, then obviously you need to move on to embolization or to surgery. Now, surgical management. Surgical management is that you open the uterus, open the belly, open the uterus, and then you can put compression sutures like this. Compression sutures on targeted areas where there is ovarian artery, uterine artery, vaginal artery, bleeders. So you can target those areas and you can close them. They are called compression sutures. There's a professor emeritus in the UK. His name is Professor B. Lynch, and he's the pioneer of these sutures. So these sutures are under his name, patented under his name. He goes all over the world, and he has traveled several times to Pakistan as well to teach this life-saving suture to underdeveloped areas. And this is very fast, very efficient to do, and it controls the atony very, very effectively. And later onwards, you know, in like 5 to 6 days, these sutures absorb because we use the absorbable sutures. So I recall I was being called for an intraoperative postpartum hemorrhage at 6 a.m. in the morning about 2 months ago. And when I was on the phone, I asked the obstetrician that what was the cause for the bleeding, and she said atony. So I told her, I am on my way, can you please put in a B-Lynch suture? And she said, yes, she will do that. So by the time I reached, she had already put in this B-Lynch suture, and voila, the bleeding had already stopped when I went there. So it is as effective as that in case of atony. This is how the B-Lynch suture looks in real time, that the uterus, we take a suture on top like this and from the back, and then we bring it in the front and we tie it as like we would tie a shoelace, like a brace suture. So on top, at the back, in the front, and then tie it. So it's amazing, it's amusing. When I learned it for the first time, I was amused. That was like obviously about 20 years ago, but like it's till date, it's very much in practice, very much effective, and I would strongly recommend everybody who's working in the labor room to learn how to put in a B-Lynch suture. Another way of management if the B-Lynch does not work is go inside, look for the internal iliac, look for the uterine artery, and ligate it. Okay, this is something which requires skill, requires a senior obstetrician. Hence, you need to call a senior obstetrician. You may need to take help from a general surgeon or a vascular surgeon to do that as well. Internal iliac ligation is very helpful, especially when you have low resources, when you do not have any resource for uterine artery embolization, or you do not have any facility for immediate hysterectomy and somebody is still bleeding. So this is your call of the day, that you can do that. So these are the blood supply of the whole uterus, and these are the places where you can put in the ligature sutures strategically to stop the bleeding from happening. They have to be done on both the sides. So it takes a bit of time, it takes a lot of expertise. Do try to go on YouTube and watch the video of ligation of uterine arteries or internal iliac arteries. It's a fantastic video. Okay, let's go to interventional radiological management of uterine artery embolization. This is something relatively new. What we do is that if somebody has been diagnosed antenatally with placenta acreta, or pregnancy with a large uterine fibroid that can cause a bit of bleeding during cesarean section, or somewhere where somebody is definitely going to bleed on you, like in placenta accreta, increta, or percreta, then what you can do is you can plan the cesarean section with an interventional radiologist. I'll give you an example. I had a 34-year-old lady. She had previous 3 cesarean sections. At 20 weeks, she had an anomaly ultrasound, and we found a placenta accreta. So we prepared her for an elective cesarean section at 37 weeks. And what we did was that we asked the interventional radiologist to put in catheters into the uterine arteries and put in balloon catheters and inflate them. And that procedure was done immediately before the cesarean section in a cath lab. And then the patient was shifted to the main OR. This procedure takes about 40 minutes to 60 minutes. And then we perform the cesarean section. At the cesarean section, the interventional radiology team will be present inside the OR. Now that the uterine arteries were ballooned already, catheterized already. So as soon as we remove the baby, as soon as we try to remove the placenta, there was hemorrhage, there was bleeding. So the interventional radiologist used gel foam through this syringe. So as you can see that this catheter has already gone through the femoral vein in the groin. This is something like an angiography. So they use the femoral vein artery in the groin, and through the femoral artery, they went all the way through there. And what they did then is that they are ready with this gel foam, that embolic particles. And when we give them the go ahead that yes, we need their help, they would inject it, and voila, the bleeding will stop. So they have these catheters in both the fem arteries, and then they will inject the gel foam, and you will see immediate stop in the bleeding. This is magical. And I have personally used it on 5 of my patients in the last 2 years. Brilliant result. We were able to save the uterus, we were able to save the life, we were able to minimize the use of blood products and transfusion. So this is something that is really, really in vogue now. And if your hospital has this facility, then what we have done is we have made a team accreta. And team accreta means that interventional radiologists, hematologists, senior obstetricians, sonographers are all internists, are all part of the team accreta, and they plan the cesarean ahead of time. We also have a 24-hour on-call interventional radiologist in our hospital. So if somebody comes in unbooked with torrential bleeding with placenta accreta, we still have the facility to do it as an emergency as well if it is not planned. Okay, look at these fantastic pictures, uterine artery embolization. So this is what it looks on the arteriogram before you put in the gel foam, subhanAllah. And once you have put in the gel foam, these are the catheters in there, and look, all the blood supply surprisingly stopped. These are the clips that we use on top of the skin. So this is a fantastic way of preventing bleeding if nothing else is working. I call it the miracle procedure, and I have seen lives being saved. This lady who I'm talking about came back to us after 1 week of discharge. She was kept in hospital for 7 days. She came back 1 week of discharge. She was perfectly fine. 3 months down the surgery, she resumed her periods because the gel foam is not permanent, it's temporary. So it will eventually resolve. So 3 months after the cesarean and after the interventional embolization of the uterine artery, she resumed her periods, and her follow-up has been absolutely fantastic since then. The only thing is that you tell them not to get pregnant in the future if possible. And for that, you have to talk about effective contraception. So what I did was I put in Mirena coil for this lady, and it's been 2 years now. So that's fantastic. Okay, the last resort, which nobody wants on their hand, is a hysterectomy. An emergency postpartum hysterectomy is usually the final resort for the management of BPH. If nothing is working, then whoever is the operating consultant or operating doctor has to have 2 people to give a consent, because consent is very important in this case, because you're removing the uterus. She's never going to be pregnant again. You know, she may be para 1 or she may be nullipara. Previously, she may have lost this baby already. So there's a lot goes into the reproductive demise of this lady, you know, if you're removing the uterus. So it is a medical legal issue. So 2 consultants should give a consent and speak to the family prior to removing the uterus. So somebody needs to scrub off, go out, explain to the family what's happening, take a consent, take a legal consent, and then come. And always when you're doing a cesarean hysterectomy, please document each and everything at the end of the procedure. We'll talk about risk management after this slide. So if you can try the B-Lynch suture first, did not work, hysterectomy is typically a last resort, more readily done for uterine perforation or placenta accreta, increta, percreta. Since the interventional radiology came into our hospital, our number of emergency hysterectomies for accreta and percreta has drastically reduced, and which is a thankful thing to happen. But again, you know, I mean, it is definitely not a dying art at all, and where these facilities are not available, hysterectomy is your lifesaver. Okay, so we have a revision sort of flashcard where we are doing the guide to management for the PPH. And so number 1 is communicate and alert all the staff. Number 2 is resuscitate, ABC, give oxygen, position flat, 2 IV cannula, send blood lab works, cross match, restore the circulation, and rapid recourse to operating theater. Stop the bleeding. Uterine massage, syntocinon, ergometrin, misoprostol, carboprost, fresh frozen plasma, tamponade, Beeline suture, internal iliac ligation, and resort to uh, other things faster, resort to hysterectomy faster. Think about recombinant factor 7A. Documentation and debriefing to women and family by a senior staff. So once the PPH has happened, a lot of shouting goes on around the lady, a lot of confusion goes on around the lady. So definitely you have to go back and debrief. This is part of your medical legal documentation, and debriefing is part of your medical legal concern also. And please document. So always remember, document what you do what you document. So there's no way that if after 1 or 2 years, if somebody sues you, that you will be able to remember what happened that day unless you have documented that and unless you have spoken to the family. So always go back to the family and talk to them and debrief them, please. Okay, so what about the risk management? Major obstetric hemorrhage is part and parcel of your risk management in the labor and delivery suite. Do practice drills. We do it every 3 months in our labor room or upon arrival of any new staff. Incident reporting. So any major obstetric hemorrhage is notifiable to your hospital quality department. You need to write an incident report, and you need to report any delays. And mostly if there is a delay in getting access to blood products, or if there is any delay in shifting to the OR, if there is any delay in getting help from the senior obstetrician or from the anesthetist, all that needs to go on an incident report in a non-confrontational way to make sure that the team sits together and make sure that there are protocols in place so that if there was any delay or if there was any error, this should not happen again in the future cases, because there will be future cases. Make a multidisciplinary team, and again, that would include your senior obstetrician, that would include the hematologist, anesthetist, midwives, porters on the labor room to do the running between the labor room and the OR, as well as the blood lab. And also you need interventional radiologists and sonographers. So the more the merrier. Talk about high dependency care. These patients have mostly lost a whole volume of blood, and you have replaced a whole volume of blood. So it's better to shift them to an ICU or intensive treatment unit for a couple of days so that they can have a one-to-one care and quality. So that takes us to the end of this presentation. I hope you understood whatever has been explained today, and this educational activity has been supported thankfully by JSMU, and that's my email address at the bottom. If you want to email me, if you have any queries, any questions in the end, please feel free. Thank you very much. Assalamu alaikum.